This is Professor Upfer, and this is the third part of our lecture on mental disorders, in which we cover the topic of depression. So, depression is a mental disorder that afflicts about 30 million Americans per year. Its symptoms include many common experiences, but each of these are taken to a high degree. They involve sadness, something that we all feel from time to time, feelings of worthlessness, changes in sleep, changes in eating, taking less pleasure in certain events than we normally would. That's what anhedonia is, and even suicidal thoughts. Now, there are three perspectives on depression, reflecting a long-standing interest in the causes of depression. Briefly, these are the behavioral view, which is that people are depressed because of their situation. It has clinical implication that's fairly clear-cut. If you change the situation, you can reduce the depression. Then there's the biological view, that people are depressed because of their brains. So if you change what happens in the brain, you'd reduce depression. And the third is the cognitive view, that people are depressed because of their thinking. So if you change how people think, you can reduce the depression. Let's look at how these three perspectives on depression have fared empirically. So, are there situational bases for depression? Does, for example, life stress cause depression? Well, there certainly is a positive correlation between stressful life events and the onset of depression. The stressful life events typically involve losses. So a person has lost something very meaningful to them. Maybe they lost their fiance to a breakup, or their spouse to a divorce, or they lost their job, or maybe their mom died. All of these would be losses with a good probability of being what's called a depressogenic life event. Loss in health, income, and so on. Now, this gives us some reason to think that the behavioral view of depression might be right. Lewinson claimed that depression specifically resulted from these losses involving the fact that fewer positive rewards were being provided to a person. The basis for his claim is a little funny. He came to this idea when he followed depressed patients into their homes and observed their mealtime dinner conversations. And what he found is that depressed patients were less likely to receive positive comments than anyone else at the dinner table. This is clearly a correlational study. There's a correlation between your likelihood of receiving positive comments and the likelihood that you're depressed. But we don't really know which is causing which. Is it that depressed people are maybe reacting to comments at the dinner table in a way that is punishing to everybody else, and therefore it's depression that's causing a low likelihood of receiving positive comments? Or is it that the depressed people are being picked on, and therefore, because they're being picked on, they're depressed? We can't know from this kind of study. But we do find that depressed people tend to have more unpleasant experiences than others in health, finances, social interactions, and professional and academic pursuits. This, again, is all correlational. We don't know which is the cause and which is the effect. Is it that depression is causing people to have bad experiences, or is it that bad experiences are causing depression? We don't know. Well, one idea that comes out of this is that maybe if you change the situation, you would reduce depression. All right. Well, here are a couple ways that people have tried this using behavioral therapy. One is to prescribe pleasurable activities. Another would involve teaching other people to ignore depressive behavior, like complaining, crying, self-deprecating, or to reinforce adaptive behaviors. Still another is a technique known as personal effectiveness training, in which you get people who are depressed to stand up for themselves and not allow people to disrespect them, and so on. Generally speaking, what we find is that simply increasing the number of pleasant activities makes no difference to depression. So if you simply have lots of ice cream cones, you're not going to have a depressed person become happy. You're going to have a depressed person who's eaten a lot of ice cream cones. So this isn't just about a lack of pleasure. You do find, however, with mildly to moderately depressed patients only, depressive symptoms can be reduced about 80% when you do the other things in behavioral therapy. But only when all of the aspects of therapy are combined with lectures, classroom activities, homework assignments, and a textbook. Now, that probably doesn't fit with your idea of what clinical treatment for depression involves. Lecture, classroom activities, homework assignment, a textbook. Those are cognitive activities, not specifically behaviors. And you'd be right about that. That does seem not at all like the standard Hollywood version of what treatment for depression, let alone effective treatment for depression, would look like. But it's a practice that came about in conjunction with a cognitive approach to depression. Now, the other thing that we see with depression is that there is an important biological basis. As we've seen previously, severely stressful life events do increase the probability of the onset of a major depressive episode, but those chances vary quite a bit by, say, whether or not you have an identical co-twin with a history of major depression versus an identical co-twin of people with no history of major depression. There's a kind of genetic liability. And we looked at what that genetic liability might be, specifically this transporter of serotonin. This again suggests that there might be a biological basis for depression. The most popular view among scientists of how you can sort of put all of these things together relies on the central role of cortisol. So the idea here is that stressful events typically evoke a cortisol response. The cortisol response is part of the fight or flight response. This is adaptive in the short term, but cortisol is toxic to certain types of cells in the brain. As a result, under chronic stress, elevated levels of cortisol induce clinical depression by affecting the transmission of serotonin. And it's the serotonin receptors which are killed through chronic stress. That's the theory. Now, there's some decent evidence that something like this must be true. So one is the efficacy of serotonin reuptake inhibitors like Prozac, which have proven to be fairly successful in treating depression, at least as long as the person is on the drugs. So typically when people go off the drugs, the depression returns. So it's as if all it's doing is sort of compensating for the already reduced number of serotonin receptors. In addition, Prozac has a number of side effects. It can involve a loss of sex drive, a loss of motivation, weight gain, patients often do need to come off of Prozac in order to reach full functioning, but it is a useful thing in sort of the short term. The other idea about depression is the cognitive hypothesis, which is that habitual maladaptive patterns of thought provide part of the basis for psychological problems, including depression. And so changing these habitual patterns of thought is thought to be one of the central goals of treatment. It's the kind of thing that you saw in the behavioral therapy being supplemented with these cognitive aspects like homework and a textbook. This idea about depression, about the cognitive basis for depression, was pioneered and advocated perhaps most strongly by the psychologist Aaron Beck. In Beck's view, depressed people hold pessimistic views of themselves, the world, and the future. And the reason that people hold these pessimistic views is that they distort their experiences in negative ways, either by exaggerating bad experiences or minimizing good experiences. So there's a number of maladaptive attitudes that have this effect. For example, if you think my general worth is tied to every task that you perform, then you're going to have an exaggerated reaction to minor failures. If you think, if I fail, people will feel repelled by me, then when you have these setbacks, you not only think, well, I'm not so good at this task, or I could practice more, you think that your worth is going down, that you're less lovable as a result. Or if you think happiness is obtained by doing nothing wrong, well, there's a good way to do nothing wrong, and that's to do nothing. But is happiness obtained by doing nothing? That doesn't seem like a very adaptive attitude. Or the idea that certain people are bad and must be punished for their villainy leads to the idea that when people are getting away with something, life and our future is doomed. Again, this exaggerates the actual effect of a few people getting off scot-free. Or the idea a person's worth depends on the opinions of others. This is a very damaging idea. Another thing that contributes to depression are certain characteristic errors in thinking. Most important is overgeneralization, where general conclusions are drawn hastily from single events. So you might say to yourself, yes, once again, my talk was a failure, just like my whole career and my general life. That would be way overblowing one individual failure. Or selective abstraction, which is where the larger context is ignored in favor of selective negative details. So you might say, yes, I got an A in the course, but I got a B on one of the exams, and that's what matters. I'm an idiot. Magnification, where negative details are used to predict failure. Good example of this came from a study by a colleague of mine, Mike Vasey, in the clinical psychology area here at Ohio State. He did a study in which everyone was asked what would happen if you didn't do well on a test, and what would follow from that, and what would follow from that, and so on, until the person just couldn't come up with anything else, or just started to repeat themselves, or refused to continue. And he compared those who are chronic worriers to those who aren't chronic worriers. So here's a transcript from a non-worrier. He's asked, okay, you're going to fail the test. What would happen? What would happen? What would happen? The person says, well, okay, I might do poorly on a test, get a bad grade in the class. That would lower my grade point average. I'd have less of a chance of getting a good job. I'd end up in a bad job. I'd get a low salary. I'd have less money to spend on what I want. I'd be unhappy, put a strain on me, I'd worry more. That's it. Okay. Now here's a transcript from a worrier. I won't live up to my expectations. I'd be disappointed in myself. I'd lose my self-confidence. My loss of self-confidence would spread to other areas of my life. I wouldn't have as much control as I'd like. I'd be afraid of facing the unknown. I'd become very anxious. Anxiety would lead to further loss of self-confidence. I wouldn't get my confidence back. I'd feel like I wouldn't have any other control over my life. I'd be susceptible to things that normally wouldn't bother me. I'd become more and more anxious. I'd have no control, and I'd become mentally ill. I'd become dependent on drugs and therapy. I'd always remain dependent on drugs. They deteriorate my body. I'd be in pain. I'd die. Wow! All from failing one test. You can see why this person is so worried. They massively elaborate consequence upon consequence upon consequence. Now, the interesting thing about the difference between worriers and non-worriers isn't just that the lists from worriers were longer, although they were longer. There was something else that was important. So let's take number 1 and number 2. Okay, so if you don't live up to your expectations, what is the probability you'd be disappointed in yourself? If you were disappointed in yourself, what is the probability you'd lose your self-confidence? And so on down the list. Now, let's suppose that the transitional probability, the probability of going from 1 to 2 is 0.9, and from 2 to 3 is 0.9. It's for each pair down the list. So it's 0.9, 0.9, 0.9, 0.9. Okay, what is then the probability, all right, that you would get from 1 to 18? Well, it would be where you multiply 0.9 times 0.9 times 0.9 times 0.9. Okay, now let's suppose it's not 0.9. Let's suppose that the probability of going from 1 to 2 isn't 0.9, it's 0.5. And the probability of going from 2 to 3 is 0.5, and so on down the list. So what's then the probability you'd get from number 1 to number 18? Well, it would be 0.5 times 0.5 times 0.5 times 0.5, going all the way down the list. Well, if you do that calculation and you multiply 0.9 to the 18th power versus 0.5 to the 18th power, you get two very, very different numbers. At 0.9 raised to the 18th power, it's at least possible, all right, that you'd get from I won't live up to my expectations to I die. But if it's only 0.5, there's hardly any likelihood that you'd get from I won't live up to my expectations to I die. In fact, it would be almost totally improbable. And so what we're seeing with the worriers is they're giving larger of those transitional probabilities, leading them to think that something like getting from 1 to 18 is a totally plausible scenario when non-worriers think that that is highly unlikely. So that's another difference in the thinking about worriers versus non-worriers, how worriers are exaggerating their risks. Oh, actually, I forgot. The person ended with, I'd end up in hell. Okay, so this is an example of some errors in thinking. Another is minimization, where positive details are used to excuse success. So the idea would be, my talk went well because my topic was easy and the audience was being nice. Or personalization, where all negative events are interpreted as caused by the self. So instead of I messed up, it's I'm an idiot, or I'm a failure, or I'm a loser. Now, the symptoms, I've said, of many, maybe most mental disorders are not qualitatively different from the experiences that most of us have had. They differ only in degree. And that's true of all of these errors in thinking. Many of us have had these errors from time to time, but depressed individuals have much, much more of them, and they have a much bigger impact. Now, if this is the case, that this is why people are depressed, then if you change how people think, you should be likely to reduce depression. So the idea here is that people think their lives are bleak, they take no action, their lives become bleak, they feel bleak, they take their feelings of bleakness, of proof that life is bleak, so they take no action, and it becomes a self-defeating feedback system. And the goal of treatment is to break this self-defeating feedback system. So the self-defeating feedback system, we can see it in experiments. In one study, they gave depressed and non-depressed subjects the choice either to participate in a study with a person who had just given them a whole lot of negative feedback on their personality, or to participate in another study. The depressed subjects were much more likely to prefer working with someone who had treated them badly than with others. And then when both groups were given positive feedback, the depressed subjects were more likely to discount the feedback than the non-depressed subjects. So here we can see that at some level, depressed persons want negative appraisals. They want to be given negative feedback. They're seeking out individuals who give them negative feedback. This is a self-defeating feedback system. So to break this is some things you might see a cognitive psychologist do. I'm not saying that you try this out on your friends and family, but this gives you a sketch of the way a therapist might deal with depression. So the first phase involves increasing a person's activities to elevate their mood. So in this phase, the therapist and the client plan the patient's schedule hour by hour, filling the day with action. So you might plan that instead of for an hour, you sit on the couch and you think about how bad things are, you instead spend that hour maybe vacuuming. Maybe the next hour you spend going on a walk with your dog. Maybe the next hour you spend talking to a friend. All right? But you're filling all of the day with action. All right? Now, this has an important effect. All right? Eventually, these activities become more difficult and challenging. But just acting is going to yield positive consequences, at the very least by increasing a person's mood. I will confess that when I was a college student, before exams, I used to get terribly anxious, and I would clean my apartment from top to bottom. I cleaned the bathroom, vacuumed the floor, until finally the anxiety went away. My roommates loved me, but it was effective. It's effective at giving you a temporary boost to the feeling that you can be effective, a temporary boost to your mood, a temporary feeling of confidence that you can do something, that life isn't necessarily bleak and hopeless. The next phase involves examining and invalidating automatic thoughts. So this would be where we start to see homework assignments. In the old days, the way this would work is the person would be taught to identify some of the automatic thoughts that we talked about. Maybe they're taught to recognize when they minimize good experiences. So they're feeling down, and then somebody says, "Oh, wow, I really like your car." And the person says, "Oh," to themselves automatically. They're just saying that to make me not feel depressed, as opposed to, "Oh, yeah, well, somebody really likes my car." All right. And so they'd say, "Oh, wow, I just did it." And then they make a mark of that. All right. And they'd count the number of automatic thoughts that occur every day. They'd write the automatic thoughts down. And then the automatic thoughts are then reviewed with the therapist. So you might go over with your therapist. Well, it says here that you have this automatic thought that the person said they liked your car only because they were trying to make you feel not depressed, and how embarrassed you were that they knew you were depressed. And then the therapist might say something like, "But is there maybe another reason why they said you liked your car?" patient might say, well, maybe they liked my car. Why would they like your car? Well, it is brand new, and so on. Right? Then you begin to identify distorted thinking and negative biases. So you begin to identify errors in reasoning as errors. You engage in reattribution techniques. For example, well, maybe the person, the patient gets to the point where they can say, oh, yeah, the person maybe liked my car because they liked my car. And then you begin to alter a person's primary attitudes. Is the world really so hopeless? Isn't there a future that you can see for yourself? Don't you think that maybe we'll all be okay in the end? Sometimes this involves experimentation. One of the pioneers of cognitive behavioral therapy was a very colorful and interesting character by the name of Albert Ellis. He had the belief that when he was in college that women would never find him attractive. And as a way of doing an experiment, he stood in a park one day and he asked every woman who walked by out on a date. That was an experimentation. And what he found is that actually it wasn't that everybody turned him down. Some people said, yeah, okay, I'll go on a date with you. All right. I'm not suggesting you do that, by the way. That kind of is a little creepy and harassing. But just as a way of showing that, an experimentation can alter your primary attitude. And so Ellis reported that after that occasion, he stopped thinking that he was just repulsive to the opposite sex. Correcting cognitive distortions is a very key ingredient in the treatment of depression. Examining the evidence behind your hopelessness. You think, I never do anything right. Really? Is it really true that you never, ever do anything right? Probably the evidence says no. Or identifying double standards. Think about that person who is sitting at night, beating herself up, saying, oh, I'm going to fail, my life is going downhill, that exam, I'm going to lose my job, I'm going to become addicted to drugs, and so on. All right. Well, would you talk to a friend like that? Would you ever find your best friend, and while she's trying to sleep at night, whisper in her ear, you're a failure, you're no good, you're going to fail? Of course not. It would be sadistic. You'd never talk to a friend like that. If you wouldn't talk to a friend like that, why would you ever talk to yourself like that? It's a double standard. Another is the experimental technique, all right, where you actually test your beliefs in the way maybe that Albert Ellis did. We're using a survey method. You think the person is saying that he liked your car only because he's trying to make you feel not depressed? Ask around. Do other people like your car? You might find it's actually a nice car. They don't care if you're depressed. Now, we find that cognitive therapy is actually quite effective. Hundreds of studies have shown that mildly to severely depressed people who receive cognitive therapy improve significantly more than those who receive placebo treatments. In fact, about 60% show a total remission of depressive symptoms, meaning once they're gone, they don't come back as long as they've been followed up by the study. In fact, clients who show improvement in their cognitive functioning, who respond to therapy, show improvements in their cognitive functioning. And these improvements correlate strongly with their improvements in depressive symptoms, meaning that cognitive therapy is working by means of improving cognition. Now, we can sort of unify these three approaches. So one thing that we see is that cognitive behavioral therapy also seems to work at a biological level. So, as an example, there's a drug known as dexamethasone. It suppresses the cortisol response. Now, consistent with the biological view, depressed patients show a lower level of suppression from dexamethasone. That kind of makes sense, all right? If they've already got a suppressed cortisol response, there's nowhere to go, all right? Now, consistent with the cognitive behavioral view, cognitive behavioral therapy actually restores the biological response to this drug, all right? So again, it seems that the cognitive behavioral therapy is working at a biological level. So-called talk therapy changes the brain. Now, more broadly than cognitive behavioral therapy, does psychotherapy work? There were early attacks on psychotherapy. Eysenck once claimed that in a study that he did, that overall about 60% of people who engaged in psychotherapy improved, but the spontaneous recovery rate was about 70%. Now, that would be a serious problem for the idea that psychotherapy is effective. But it's important to notice that Eysenck did this study in 1961. That's 20 years before the development of the DSM-3, meaning that the diagnostic criteria in those days were very lousy, no better than expected by chance. So that's part of the reason why early on psychotherapy didn't look like that it was being effective. Basically, people didn't know who was and who wasn't depressed. When more rigorous criteria were retrospectively applied to his no therapy group, the no therapy group only spontaneously recovered about 30% of the time, suggesting that the 60% number was doing better than you'd expect from placebo. Also, there have been meta-analyses of therapy outcomes. So this is when you combine the results of many studies to look at the individual effect sizes of each one of them to come out with a likely effect size given all of the data. Smith, Glass, and Miller reviewed 475 different therapy outcome studies comprising 25,000 patients in all. They found that the average person who receives therapy is far better off at the end of it than 80% of the persons who do not. And genuine psychotherapy leads to more improvements than placebo treatments. Psychotherapy also works as well as or better than drugs alone. Even for severe depression, cognitive therapy has moderately greater effects than antidepressant drugs alone. For some disorders, like panic disorder, depression, obsessive-compulsive disorder, cognitive therapy has similar effects as psychotropic medication. Moreover, typical improvements are still found when patients are studied months or years after treatment, which isn't true of the drug therapy. And also, it doesn't seem like all psychotherapeutic styles work equally well. Cognitive and behavioral therapies typically has consistent advantages over other approaches, which is why CBT, or cognitive behavioral therapy, is the preferred choice of both insurance companies, hospitals, and academic psychologists like me. Okay, so stepping back to think about what we've learned about mental disorders. I've said that mental disorders are just dysfunctionally magnified reactions to ordinary events. And we've seen that that is the case with phobias and depression. Everybody has a fear of ordinary dangers, but it's magnified dysfunctionally in phobics. And what we found is that systematic learning is an effective treatment. So again, this is and learning how to rethink your experiences. Same thing with depression. We see that depression often involves an irrational hopelessness about ordinary life. And again, what was effective is systematic learning and thinking as treatment. So again, it doesn't help to think of phobics and those who are depressed as being crazy. It's better to think of them as being ordinary people with a magnified reaction that needs to be rethought. Now, there are concerns about the idea that mental disorders are just dysfunctionally magnified reactions to ordinary events. Part of that is because what is ordinary changes over time. A child who is restless and has difficulty concentrating probably would be considered rather normal prior to the existence of schooling. But when schooling is ordinary, that same behavior becomes a clinically significant problem and one that's likely to lead to diagnosis of ADHD. Again, a person who has trouble finding how words are made of individual phonemes probably would have no problem living life in a society that doesn't have reading. But if you don't understand how words are composed of individual phonemes, it makes it really hard to learn to read. And so in a literate culture, that same problem of identifying the individual phonemes in words becomes a mental disorder known as dyslexia. Now, I don't mean to suggest the Sally principle can solve every mental disorder. There might be some exception. Drug addiction, schizophrenia, and dissociative disorders might be considered a challenge. But I'd urge you to read your textbook. Schizophrenia is probably a legitimate case that goes against the Sally principle. But as you'd read in your textbook, drug addiction, like a lot of other things in learning food rewards, is pretty much just learning. And dissociative disorders turn out to really be a fiction of Hollywood's imagination. So the Sally principle works pretty well. And that's kind of the bottom line on this lecture for mental disorders.